This case demonstrates some unexpected findings during the assessment of proximal anastomosis. The patient was a 73-year-old man with two-vessel disease. The surgical plan was to do an on-pump coronary artery bypass graft, a Lima to LAD graft, and a saphenous vein graft to circumflex. The Vera QC system with imaging was used for pre-cannulation epiortic scanning. This revealed a couple of surprises. Plaque were seen on the distal wall for the planned cannulation and cross-clamp sites. There were several lesions on the distal wall. The calcified plaque gives distinct shadow underneath it. We also see indication of soft plaque on the proximal wall to the probe. These findings changed the plan of the procedure for both cross-clamp site and cannulation site. These were new findings, not known before the procedure. TTFM was measured while the cross-clamp was still on and the heart was still empty. Measuring at this moment gives us an indication if anything is wrong with the anastomosis. There is no pulse, so the pulsatility index should be very low. Typically, a value below 0.4 demonstrates an open graft. In this example, it is 0.2. We also see good flow at 55 milliliters per minute. TTFM was thereafter measured after the cross-clamp was removed while the patient was still on pump. The flow pattern was regular and nice, and recognizable for a standard Lima to LAD graft. The acoustic coupling index is green, indicating reliable measurements. Pulsatility index is low at 2.6. Flow is good at 40 milliliters per minute. Diastolic filling percentage is above recommended value of 70. This altogether indicates a well-functioning graft. Then TTFM of the saphenous vein graft to circumflex was measured. The flow curve looks noisy and inconsistent, with high pulsatility index and low flow. Papaverine was first used to identify potential spasms in the coronary bed, but without any findings. A closer visual inspection of the proximal anastomosis indicated this to be a bit flat. It was decided to use imaging to scan the anastomosis for a morphological assessment. Imaging revealed that the blood flow was restricted. This led to a second visual inspection and the identification of a fiber optic band that was then removed. To the top left, the saphenous vein is coming into the aorta. The toe of the anastomosis is a bit flat, and you see that it restricts the flow into the vein. After revision, TTFM was measured, and the flow pattern is consistent with improved flow parameters. Pulsatility index is very good at 1.8. Flow at 26 milliliters per minute is normal. Diastolic filling percentage is 57, which is also normal for this kind of graft. In summary, epiortic scanning helped to guide the clamping and cannulation sites to areas with neither calcified nor soft plaque present, and thereby reducing the risk of stroke. TTFM revealed that something was wrong with the graft, and imaging identified the cause of the problem and enabled the revision before closing. This case emphasizes the importance of combining the two techniques throughout the procedure for better informed decisions and best surgical outcome for the patient.